Okay, hello everybody. I think we're gonna continue to let people in as they sign in. We know it's the middle of the day. We're welcome to the restart of the webinar series, the educational series from the MGH Pediatric Parent Advisory Board. Today we're gonna start with a session that we did previously. We call it Stroke 101. And we are hoping that it's helpful as a frame of thinking about how the brain kind of works, but most importantly, how the brain develops, learns, and recovers after injury. So I'm gonna start sharing my screen. We're letting more people in to the meeting. And I'll take advantage and say a couple of things for those of you that might be new in the group. There's 3 dots in the picture, in the frame that has your name. And we ask people to rename, just put in your name, where you're from, and how are you related to the pediatric stroke journey. And that means, are you a parent? Are you the parent of a kid that had a stroke? Are you a stroke thriver, or are you a healthcare practitioner, a therapist? And that way we can also get to form a community through the chat. So take advantage. We want these things to grow organically, and you'll hear a little bit more about the story. But if you see anything any questions, any comments that you want to do through the presentation, please put them in the chat. Gretchen Murphy is going to moderate the session today. So she is going to, at the end of the presentation, take the questions that were in the chat, and then we'll give you the microphone. If you want to unmute and put yourself on video, that's great. So we get to interact more, and you can ask your question yourself. If you don't want to do that, Gretchen would take the question and give it to the speakers or to whomever is directed during the talk. There's also going to be, we're going to put some links in the chat, and that's where we have been putting all the materials that we've been generating in these last 2 years. So please go into those and see if you find anything helpful. And this one will be there in the next couple of weeks. It takes us some time to edit the seminars. Mara, anything else that we should be talking? Gretchen, anything that we need to announce? Good to start? Okay. So today I'm gonna be talking. I'm gonna be presenting a little bit of how we think about the brain. There's gonna be some anatomy. That is not to make anyone scared or expert in the anatomy of the brain. It's something that you already seen and you've already experienced, because we all have a brain. And it's a way to put some terminology. So when we are talking about therapy or accompany the development, we have some terms that might be useful also to ask questions, but to understand what some providers and your team of kind of consultants is telling you that can or may be affected, could be challenged or not working, and that you need to work on. So we're hoping that we also address with Mara Yale, as you guys know, she's the chair and this year co-chair with Gretchen Murphy of our the MGH Pediatric Stroke Parent Advisory Board. And she's been spearheading these webinars for now some time. And she's gonna also walk us through, as we've been doing in all these educational series, her own experiences. She talked about other kids in the past. We did this in the very first pediatric stroke workshop in person in Boston, and we thought it was pretty useful to see some of these things in live action. And we're going to be talking about babies and the development of certain functions in babies, but the concept of how the brain learns in a sequence is what we want everybody to think, even if your child or yourself have had a stroke later than as a baby, because basically when you have to relearn something, there will be a sequence that needs to be recreated. So even when you're hearing a lot about a baby, try to see how it relates and it applies to things that you may have questions at the end of the presentation. And we always love feedback. We'll try to send a survey at the end of the presentation through the mailing list to see what you guys want to hear this year. We have already a series of webinars lined up based on that feedback that we received in the last few sessions, or the last 10 sessions that we've been doing. So, and again, this is worked together. We are doing it with the patient as the protagonist. And because some of them are very little, we have the parents representing them. So thank you for joining us. And I'm gonna start with where we are. So this is MGH in Boston. For those of you that are not around here, this is in the United States, East Coast, up in north. We have a lot of snow and cold winds. And we are a large institution that has a pediatric hospital in it, and it goes all the way to adulthood. And there is a rehab associated hospital called Spalding Rehab. And that's why we get to take care of people before they're born all the way until they're a senior. So these are financial disclosures. I do have research that is funded primarily by NIH, foundations, and small industry research agreements. They do not conflict with any of the materials that we're going to be discussing. And Mara Yale, as you guys know, is a doctor in geophysics, computer scientist, project manager in her former lives. And she tells you a little bit more about this, but she's also been a Feldenkrais practitioner for many years and is a parent coach. So we are very glad to have someone with her expertise and intertwining all these skills. Again, nothing that we talk about it in the webinars, any of them is supposed to replace your medical care. We really want you to be empowered with some understanding or knowledge that you can create for yourself to enable that communication with your providers. And also to know what to ask and where to go. But remember that if you have questions, please discuss them with your local practitioners. You can also contact us if you have, if you want a second opinion, if you want to contact your providers, we're happy to try to facilitate those communications as well. Why are we doing this series of webinars and educational series? Because most of us have encountered this either ourselves or with our patients, which is from the time that you get the diagnosis, which is when all the distress and action, and Mari's going to tell us more, so I don't want to spend too much time. The first 6 months are pretty intense. You sometimes are in a rehab hospital, sometimes you have intense rehabilitation, and then life changed forever. There is a million list of to-dos. There is a ton of different medical appointments. You go on for the next 18 years of childhood, becoming an adult, intertwining with healthcare for addressing the challenges that may arise from that injury to the brain. Life goes on and you move into adulthood, and that's a very difficult time as well to transition into a different healthcare system, which is the adult healthcare system and all the needs of an independent life. So this is our mission. So we've been working with the parents for more than 7 years now. I started with tapping on the community and understanding, and we all started with a mother in my first clinic as a faculty 10 years ago saying, why am I coming here? Everything I found that I have to do for my child after you guys told me the stroke and what it happened, I have to pretty much do it by myself. And I asked her to send us a letter and specify a little bit what those things were. And then we did a little bit of a field research and then decided that we need to work with the parents to really understand what this journey is about. And then this turned into a group of parents, practitioners that are getting together to really advise what are the resources that are missing out there. And this is one of the resources that we want to put out. And there is a website now where you can find it, a YouTube channel. But we really want to improve the lives of these kids by building a community and to empower the families. And in this way, we believe we can really increase access to care, but advance the treatments as well. It's both ways. We are learning a lot here. I always say, as a neurologist and a stroke neurologist and critical care neurologist, I only had 2 weeks of rehabilitation training. Thanks goodness, we have a physiatrist, which is this expert in rehabilitation, which is Dr. Wisher, which has expanded this. But basically, we are struggling with a really disconnect between what happens outside the acute care and in the community, and as far there you get from central hospitals, the more difficult the challenges are to find the care and the needs that the kids may have. So we started with 2 in-person workshops back in 2019. Our idea was to keep them every 6 months. The next one was supposed to happen in April 2020. As you guys know, we were in plain surge of COVID in the East Coast, and that was not possible. So very quickly, we turned it into, in those sessions, we had the families coming with the kids, and there was childcare, and we have different speakers, and then we have small workshops, which is one of the tables. And then we adapted, as you guys have to do throughout the pandemic to support your children or yourself. And we adapted to a webinar remote format. And this now expanded the access of this series, not only to people around the Boston area, which were the people that could drive. We got in those in-person people from Maine to New York, but this now made it available to a lot of people, even not in the US, still in the English speaking. And we're working on translation subtitles for our videos, so all people from other languages also can access this information. So these are the places to look for the information. And we so far have had more than 10 events. And as you can see, every event has a particular frame and a theme that is something that we're trying to address. And we always start with a family and a case and how that particular challenge presented and was dealt with. And then we have the experts like speaking about that. And then we have a nice Q&A session. These question and answer sessions go beyond the hour. So for those of you that can stay, you're welcome to stay. And as you can see, some of them we've been separating and having second sessions also to address more questions that came from those sessions. So I'm going to start with the anatomy. It's very basic stuff, and probably some of you have already thought about this a million times, so I apologize if it is redundant. To bear with me, it will have a purpose that applies directly to function and experience in a child recovering from a stroke. So when we think about the vascular system, we have arteries that come out of the heart, and we have veins that come back to the heart. As you know, the lungs are in charge of oxygenating and putting the oxygenated blood into the circulation and the arteries that take it to the head. But when you are in utero, when you're a fetus, that is not how oxygen gets to the baby. The mom's lungs is going to be providing the oxygen through the placenta. And as you can see, a little trick here is that the placenta goes through the liver very quickly into the heart. And instead of going into the lungs and coming back to the heart, it crosses directly to the arteries and it gets a straight shot to the head. And that has a purpose to provide the brain that is developing. It has the highest metabolic demand with the most oxygenated and highly nutritious blood coming from the placenta. When the baby is being born, that means during a vaginal delivery, a C-section, with labor or not labor, there is a separation that needs to happen between the mom and the placenta, and that involves clotting that is very specifically happening on the mom side, not on the baby side. But that's a perfect time with a little bit of distress, with an infection, with fever, and other risk factors that we are getting to understand to make clots that may travel directly, and as you can see, very favorably, directly into the brain. And that what makes the perinatal stroke that we're going to be in particular talking about today, one of the most common types of stroke, as common as a stroke in the young and people less than 55 years of age. And it's very different, and never read things about stroke in adults and recovery when you're looking into the eyes of a child that has experienced injury, because the brain is in full development and has a lot of plasticity, and the outcomes do not compare and the interventions do not necessarily compare. Although we do believe in the principles do apply to adults that are recovering. And that communication that exists in the heart during the fetal life, when you are born and breathe in, that little wall has a flap. It closes, and if you don't close it, you call it patent foraminal. And maybe you guys heard about this. Some people can have strokes because this hole is still open. But in general, these babies, 3 out of 4 will close that in the next few weeks, months, sometimes a couple of years. And that makes now the lungs be able to filter a lot of the clots that normally form in the body. So this is something important to consider. And I only want to talk about this because if your kid does not have congenital heart disease, okay, the chances of having a stroke, having had a stroke at birth, are probably close to 0. Because once the placenta is separated from the baby, most of the strokes are coming from this conundrum of separation of the placenta, and the recurrence is really, really, really low. If your kid has a clotting problem or a congenital heart disease, then there might be risk for a secondary stroke or another stroke, and there should be interventions to try to prevent it. So this is what I call the broccoli brain. We all have a three-dimensional view of a tree. So a broccoli head, a tree, and it helps me because when we start cutting into MRIs, everything becomes very gray and white and is changing in planes, and I'm flipping it. So if you can keep the three-dimensional structure of a tree, and I'll walk you how I think using the tree to relate to the brain, with a canopy that is basically the cerebral hemispheres, a right one, a left one, connected at the middle with the corpus callosum, and a stem, which we call the brain stem, that connects the brain with the spinal cord, which is a big root that gives rise to the nerve roots. And then I always use the analogy of a backpack on this little brain here. It's called the cerebellum. It has a lot of functions in cognition and coordination and emotional regulation, and we'll see how we can use it in rehab. And this brain, the broccoli brain, is being fed by blood flow that is coming from the heart through the aorta, carotids, to the most of the brain. 2/3 of the brain are pretty much provided blood flow by the carotid arteries. And then the back part of the brain, which is very important, including brainstem, is provided by these arteries that come through the branches of the subclavian artery through the spine. You see these little rings are in the bony parts of the spine on the sides, and those are called the vertebral arteries, make the basilar artery, they get together and they feed the back of the brain. And those are the arteries, and the brain is the very unique organ in the body. The veins do not go along with the arteries. If you look at your arm, inside the deep arteries, there is always a vein or two veins paired per artery. That's not how it works in the brain. The brain has a very specific system of venous outflow, and those are called sinuses. So dural venous sinuses. In case that your kid was diagnosed with dural venous sinus thrombosis, that's what we're talking about when we speak about that. And I'm going to use these two pictures to tell you that there are different types of stroke. And we divide them this way because at the end of the day, stroke means the sudden onset of loss of neurological function, meaning I cannot speak, I cannot see, I cannot move, I cannot think, I cannot behave, or I cannot wake up. Those are all neurological functions. If they happen very rapidly, we call that a stroke, like meaning very fast. It doesn't tell you what kind of thing is happening to the brain. It's telling you that the brain is experiencing a really acute shortage of blood flow. And that can happen through the arteries, the veins, and it can be what we call ischemic, or it could be a hemorrhagic. And I'll walk you through this. What is an arterial ischemic stroke? If you were diagnosed with an MCA, ACA, arterial ischemic stroke, this is what we mean. Usually there is a clot, most commonly in babies, that travel. In other cases, the vessels narrow or there is thrombosis that plugs an artery, decreases the blood flow, and then you have ischemia, lack of blood flow to a part of the brain. And this is what we call the core of the stroke. And usually the area that is very close to that clot doesn't get the luxury of receiving blood flow from other arteries that are not occluded. But in the case of the rest of the tissue that is at risk, and it could be giving you symptoms. You could be completely paralyzed, but that doesn't mean that you will be completely paralyzed. When you present this area that is a tissue at risk, it still gets blood flow from the other arteries through processes called collaterals and vasodilation. But this is what we try to treat in the acute treatment. And we're going to have a speaker that is going to walk us through acute treatments in stroke later on in the series next year, Dr. Becky Eichert. So stay tuned for that. And we are working, we have done a lot of progress in this area, like improving the outcome after acute injury. Unfortunately, we need to know exactly when the stroke happened, because if we do something, we can make the brain bleed when we reopen the vessel. And in the babies, that's not possible, because the only presentation we have is seizures most commonly, or an asymmetry. And that is only many, many, many hours after who knows when that little clot came in and occluded the vessel. And as you know, these clots can have thrombin, and that's what we use Lovenox and heparin, or it can have platelets, and that's what we use aspirin. And TPA gets rid of pretty much the thrombin that keeps the platelets together. So for babies, TPA does not apply because we don't know when the stroke starts, basically. And the next thing is to think about venous stroke, and they can also impair your blood flow, because what they're doing is really making the system get clogged. If I have a clot where the drainage of a sink is, the sink will overflow. And if it overflows a lot, then it can also cause hemorrhage. So you start with lack of blood flow, and you can end up with hemorrhagic stroke. And hemorrhagic stroke, it directly can happen from a vessel that rupture, an AVM, an aneurysm that directly bleeds into the brain. And these are important things because the brain recovers differently from the different types of stroke. And this is a conversation you may want to ask questions to your neurologist to understand better what happened to the brain of your child. So I'm going to pass it here to Mara, who's going to introduce us to her story. And then I'm going to come back and talk a little bit about some of the anatomy behind this. So pay attention to whatever you can observe. Mara, it's all yours.
Thanks, Patty. So Patty is our neurologist and has been since my younger child was 6, but was not directly involved in the story that most of which I'm going to share here, which was in early infancy. So I have 2 children, Zoe and Mia, and I had a full-term birth. Actually, can you go back? But you went back too far back. So Zoe was 2.5 when I had Mia. Mia was a full-term birth, and I had attempted a VBAC, but I ended up with a second cesarean. But the APGAR scores were normal. Mia was big, 9 pounds, 5 ounces, seemed very healthy. Next slide. Until 2 days of age. And at about midnight, when Mia was 48 hours old, I was breastfeeding and I noticed jerky leg movements in Mia's right leg. But it was, infants make jerky movements, even though it was my second baby, I wasn't worried by that. And I had sent Mia to the nursery so that I could sleep because I'm a single parent. And the hospital pediatrician came in the middle of the night and said, your baby's having seizures and needs to be transferred to a larger hospital. So there I was 2 days post major surgery, standing up, watching my infant taken in an isolette with ambulance to Mass General Hospital. Next slide. And I'm sharing those, scary moments to connect to all of you, because I'm sure that each of you has your own scary moment, and it may have happened around this time or at an older age. For me, I was balancing from really the very beginning, fear and uncertainty of the unknown with hope and the power of neuroplasticity, which in some strange way, my life path had prepared me. Next slide. So back in my early 20s, I discovered this method called the Feldenkrais method, and it was the only thing that helped me rehabilitate my shoulder. That my father was an orthopedic surgeon. He nor his colleagues nor any of the therapists could help, but learning to move in slow and gentle ways actually helped me regain function myself. And the process is really applied neuroplasticity. So I'm sure that most of you have heard of neuroplasticity. It's really the ability of the brain to form connections and new connections based on experience and learning. Next. So unlike previous presentations that some of you may have seen, I'm not going through Mia's full development. Mia is now 12 years old, thriving as a non-binary child. So I'm going to endeavor to use gender neutral language, even when I'm referring to Mia as an infant. And I may challenge Patty to do the same. This was Mia on the first day of 7th grade at 12 years old, biking to school. Mia's bilingual with Spanish and English, loves to play sports, ice hockey and soccer, goalie, and is really thriving in every way. And in these workshops, we like to talk about not just pediatric stroke survivors, but pediatric stroke thrivers. So I'm going to go back in time to the beginning, because most of the photos and videos we're showing today are from early infancy. So when you know that your child's had a stroke at 2 days old, and you don't know when the stroke happened, but may have been late term in utero or sometime during or just before or after birth, you're kind of in this hypervigilance. When am I going to see the signs? The seizure stopped. Mia was on anti-seizure medication till 3 months old. And at 4 months old, Mia was pretty consistently fisting that right hand. So you can see that. And it showed up in some relationships to gravity and not in others. So there are 3 video clips we're going to show. Next. So Patty's going to play this video clip. This is actually Mia at the Mass General Hospital for an appointment. And you can see Mia's trying to play with that toy with the right hand and knocking it off, but not particularly skilled. And that right wrist is pronated or turned inward. Next clip. And I'm not sure if you shared in a way that the sound's on.
The sound is on now, yeah.
Okay, so here's Mia on their side, and you can actually see that the right side, which is Mia had a left middle cerebral artery infarction, so it's a ischemic stroke. And here gravity is helping Mia with that right hand. So by hanging it downward, Mia was able to use both hands to play with the corner of that pillow. And then when Mia got tired, they rolled to their back. Okay, and just before you play this, I want to talk for a minute. So sometimes I would see Mia fisting or pronating that right hand, and I would get more worried. And there's this feedback mechanism always between parents and children. And especially when there's some kind of early neurological injury, there's this, it can be enhancing the anxiety and worry when you see something that's worrisome. And in this next clip is the hope. And it's the hope, and I happen to catch this really magical moment. So you're gonna see Mia playing with both hands and with shadows of both hands at 5 months. And I'll just let it play because I think you can see really the child's full intelligence. And part of the intelligence is by watching what Mia's looking at one hand, looking at the shadow of one hand, touching one hand with the other hand, looking at what those 2 hands are doing together, and tracking all of this with attention. And the capacity that even a child as young as 5 months has to do that is really remarkable, and is part of what leads us to say that these children, many of them, are stroke thrivers.
So thank you so much, Mara. These 3 videos were picked very intentionally. So we talk about that area of the brain that when you have a clot can get damaged. And what is important is to maybe know a little bit more about what potential challenges could come. And we're gonna walk through a particular set of kind of how the brain is mapped, but we're gonna hinge on the motor system. And I think that the last video also very much represents the message that we wanna like repeat over and over and over. It's not one only modality. It's not sensory, it's not motor, it's not language, it's not vision, it's an experience. And you can see it from every single of the videos, but on the third one is very clear how she's integrating her vision with the movement, and at some point the other hand comes in and touches that hand. Remember, when we have injury, we might have sensory deficits, which are very difficult to pinpoint in young infants. The fact that she uses another hand to touch that hand is telling me that she's using other parts of the body to sense that and to map that part of her body that she's trying to connect with. So you guys probably seen or heard about the MRIs. The MRIs look like this. And in general, it's like different sections to the broccoli brain. As you have to imagine, the kid is lying in a stretcher. In this case, the feet are towards you. And because of that, this is up, this is down, the back of the head, and this is the left side, and this is the right side. But importantly is that the MRI has thin sections that go all the way from the bottom of that tree to all the way to the top of that tree. And as you can see, if I cut here in this line, you can see the stem of that tree. And that's why I wanted to use the tree analogy. You can see the canopy that is flowing around the tree as if it's falling around that stem. And then this is what I call the backpack, the cerebellum in the back thing. You can see it looks different than the rest of the brain. And that's how we look at where the injury happens. And the brain in the canopy does all the high cortical functions. That tree has a tree house we call the basal ganglia and the thalamus, which are relay and integration centers, as if you want a command center for things that are coming in and out of that brain. The brainstem has the primary vital functions and also all the conduction of what goes up and down between the brain and the body, the spinal cord, the ears, and the eyes in particular, and the smell just have the direct pathway into the brain without having to go up and down through the brainstem. And this, when there is an injury, this is replacing now the broccoli brain for all the little different folds the brain has at different areas, it is important to know what is damaged, and important to know in two ways. The first one, and this is Mia's, with permission of Mara, MRI, and it's important to know because the first thing is what is affected, what is not affected. So this is an unaffected brain MRI section, more or less at that level in the line. And this is what happens in a particular sequence we have that allows us to see the acute injury. This lights up in white as soon as there is lack of flow into the brain. And you can see how large this stroke is in size. And if you take, this is the left hemisphere, it's more than 2/3 of that left hemisphere. This is the classic shape, the territory of a full MCA, middle cerebral artery stroke. And it's one of the most common ones. Why? Because it presents with symptoms most commonly. Not because there are strokes in other parts of the brain that are not common, it's because we don't have tools to detect it so early. So in perinatal stroke, this is one of the most common strokes. But I want to point out two different outcomes in two different patients. And this one is Mia's. As you can see, this is normal brain, and in little white is a scar, okay? We call it gliotic scar, and a little bit of cyst and fluid, which is the tissue that has been lost. But you can tell for yourself if this is the whole story. What happened in acute is not what ended up happening to the brain. There is process of plasticity and keeping and maintaining neurons from dying and not being used that happens during the recovery. And this is more than a year after the injury. And there are other kids that we don't understand very well why, and that's why there is so much research going on. And that instead of having that small scar, they have the scar, but in a big cyst that replaces the tissue. And that has a very different also functional outcome. So it is important to know where, because in a baby brain, the areas that are set up to do language or mapping the body for sensation or vision are established, but they are not fully developed. And that's very different from a stroke in a 2-year-old or a 6-year-old or an 18-year-old or a 70-year-old. And the younger you are, the more we believe you can adjust your networks to make the work that needs to happen and to flip things to the side of the brain that is not necessarily affected. So we're gonna go through how is this brain kind of language mapped, and I'm gonna go quickly here because we wanna focus on the motor part. So we have the brain, the broccoli tree with the brainstem. I told you that when you come out of the skull, then continues inside the spine, the spinal cord, and that's the big root, as I call it, that connects the body with the brain, and not just the skin and the muscles, but also all the organs and everything that is in the body. And those nerves are called nerve roots, and they take off at different levels in the spinal cord. As we said, that brain, the canopy, the canopy of the brain is the hemispheres, the backpack is the cerebellum. And very importantly, this is not just, whenever I'm gonna show you, it's not one spot that does it. It's an orchestra, it's a symphony. There is no solos here. So when I'm gonna show you the areas is where some of the primary functions occur, but I'm gonna also demonstrate how these other areas connect and make sense of that primary information. Inside that brain, you have what we call the nerve cells, which are the neurons, and those nerve cells connect to each other through these arborizations, dendrites, but also they project long, like all the way to the feet. In fact, all the way to the bottom of the spinal cord. They make another connection with another nerve cell, and they go all the way to the feet. So you can think about it. These are pretty long projections. We call them axons. And like wires, they're connecting through electrical activity, and they are insulated with something called myelin, which is a process that develops in utero and outside the baby all the way primarily until early childhood, 6-7 years, but it goes on all the way until you're around 26, 27 years of age for your frontal lobe. So these two elements, the oligodendrocytes that make the myelin, the neurons, are very important, but not less important of those vessels that keep all the needs, and a lot of other cells that have very specific functions in the brain called the glia. So if you look at the canopy, now I could talk the brain, I'm looking at it from this side. And then let's say I'm looking at it from the left side. And you can see in pink, they're the primary motor and sensory areas. They're specifically mapping to a part of the brain around these sulcus, which you call the central sulcus. And then if I open up, there is a sulcus here and I open it up, then this separates the temporal lobe from the frontal lobe, from the parietal lobe, from the occipital lobe. And as you can see, you have sensory, motor, visual, auditory. But what about making sense of words? I need then auditory association areas in yellow, and even more, I need multimodal associations. I cannot make sense of words sometimes without having seen an object. So I need information from the visual field to tell me that bottle is bottle and what is a bottle. So when I'm gonna say bottle and I'm gonna mean bottle, I will need information coming from the visual cortex. I will need information coming from the auditory for the words that I'm making. And so you can see how the primary information is not the only story. There's a lot of associative cortices, and that's what I'm talking when we talk about networks. And this in green, kind of like the anterior part of the frontal lobe is the part that does the emotional cognitive functioning. And in the stroke group, this is one of the most affected parts of the brain, the frontal lobe, either directly or indirectly. So most of the kids, either through their challenges in other spheres or directly by damage there, will experience behavioral and cognitive impacts in their development. So remember that I told you motor and sensory. The brain goes even finer in where it maps everything. So if you're talking about the mouth, that maps all the way right here. If you're talking about the arm, it's a little bit higher up. And if you're talking about the foot, you're gonna go down into the in between the two sides of the brain, the interhemispheric fissure. So right here we have the foot. So for example, the MCA will affect your hand, your arm, and your mouth, but it will not necessarily affect so much the nerve cells of the foot. But because it cuts the connection that come down, because it cuts the white matter, it might present with weakness, but the recovery and the journey of recovery will be very different if you knock down the nerve cells or just the connections, like in the case of an MCA for the foot. And it's very different, and this is if you were to put in number of neurons that you have for what we have here, the sensory or the motor. How does the brain sees the body? This is how it will see it. And why do we have such big hands and big lips? Because we really have a concentrated, much finer function in the hands and the mouth. And the mouth is not just the mouth, it's all the muscles that allow you to speak. You can hear my accent. The accent comes from all the consonants that I have to make with my tongue, my lips, and my palate, which were not trained as a baby in English. I was born and raised in Italian and Spanish. So those connections need a lot of fine tuning. That's why you have a ton of neurons representing and mapping for those areas, both sensory and motor-wise. Very important to the videos that we're gonna see in a little bit, how the mouth and face is right next to the area in the brain that integrates and computes for the hand. And you will see it in the kids, how they constantly take things to their mouth to help with the mapping of that particular domain or whatever they're working on. And we go on, and that mapping, so if there is a nerve root that comes out here, it maps this part of the body. If it comes out in like the cervical spine 6, it comes to the thumb, et cetera, et cetera. So there is a very strict organization to know where the information is coming from and needs to go. Same thing for the visual system. The interesting part, which I didn't mention here, is everything is crossed in the brain. Okay, so even the vision of one side of the universe will go and represent on the opposite occipital cortex. And it does it through a station in the thalamus, which is this big coordination center that we have for sensory integration and for limbic functions and many others. But it's way more than just the occipital cortex. And if I got damage, I'm going to have maybe some visual field cut, which is this represented here. The visual integration is necessary even to speak, to go to memory, to use it for mapping of motor functions. So the integration of visual information is very, very necessary for many different domains. This is where language maps. So we hear things to this auditory, we make sense and decode them as words in this thing called the Wernicke in the temporal lobe, and we send it to the frontal lobe to execute a motor instruction plan that allows you to phonate. And if I'm using the vocal cords, I only can do A, O, E, and all the rest is happening with these little muscles that I was talking, lips, tongue, and palate, to make the consonants in the rest of the words. But if I want to say what something that I'm seeing is, I had to connect to the temporal lobe, which is the language area. But if I want to put it in space, I need to go to the parietal lobe, where a lot of the visual spatial integration happens. That's the where pathway. So I'm just showing you these areas just to say it gets more and more complex. And again, when we're talking about communication, not just production of language, it's way more than just the words. And I'm not going to play the videos. We have it in the language session. So you guys want to see that communication is a lot of more than just the words. There's expressions, there's body, there is emotional communication. And this one plays just when I try to go forward. So I'm going to do the next 5 minutes into this part of the presentation, which is how do we integrate sensory information coming, and I'm going to concentrate a little bit on the hand just to make it practical, or the leg. How do we integrate that sensory information coming from something in our body to produce a movement? So first we have to get the information up to the brain to think about it. If it doesn't reach the canopy, it's not conscious. You cannot be aware of. So that's how different sensory modalities, touch, temperature, pain, muscle and joint information, where is my finger, where is my wrist, has to come up through these nerve roots that go into the spinal cord. And you can see one nerve neuron, and then the second one in blue, and a third one that comes from the thalamus and goes into the cortex to that area that I was telling you maps up there for the hand. And this is, depending on what modality it is, will go to a specific type of networks. So you can see that there is a lot of more than just touching and feeling. Is it cold, the wall? Does it have texture? How big? But also what position my hand is in. All of this information is being integrated. And then if I want to move my fingers, I need to tell the motor area of the brain that codes for the hand to go down. And this is a single nerve neuron that goes all the way down through the brainstem into the spinal cord and connects with another neuron that then connects with the muscle. And you can see here now the last section is the spinal cord and that motor neuron that goes to the muscle to tell the muscle contract. We want to move. I want to now emphasize a little bit of what happens if I want to move my elbow and do a flexion. There's going to be a part of the brain that says to the biceps contract, and there's going to be another part of the brain that will tell the triceps do not at the moment. Because if not, if we contract both, we end up locked and we don't have a movement. And if we don't have both acting in sync, we will have this kind of movement, okay? An interrupted, not a smooth movement. So, and then all of this is integrated in part at the spinal cord level. So it's a lot of reflex, things that we're not thinking or aware of. And one of the primary reflexes is called the myotatic reflex. So a single sensory neuron connecting at the spinal cord, not in the brain, to the neuron that is producing the movement. The same neuron that is going to need to be used when the brain wants to use it. Okay, so it's the same minion that it takes you to the muscle that needs to be available. And this reflex is there, so we are not lying flat in the ground because of gravity. Whenever the gravity pulls the tendon, which is the same that we do when we do the reflexes with our hammer, that muscle feels the stretch with this sensory neuron that tells the motor neuron to contract a little bit, okay? And it's just to have muscle tone. You can find that the more anti-gravity, the more tone you have, the more towards gravity, the less tone you're gonna have. If I take the boss, the neuron in the cortex out, and this one is now at the mercy of just this reflex, this can increase that tone, and that's what we call spasticity. And it's very important to think about both. This is happening if I had a stroke. I will have a spasticity. It's a classic feature of cerebral palsy. And it is important to know that it has a sensory system, because I can work with the sensory to trick this spasticity. I can also work with the motor and gravity to trick the spasticity. And why do I want to trick the spasticity? To allow more movement, that allows more experience, that allow more learning. And this is another trick that we use in rehabilitation a lot. And PT and OT and everybody that does experiential learning uses cerebellum, the backpack, to inform the brain. And the beauty of the backpack is the only thing that it needs is variation. So if you're doing the same exercise, the cerebellum shuts down after the second, third iteration. But if you are putting me on top of a horse, or you're taking me to an irregular surface, the cerebellum constantly gets a lot of information about the proprioceptive system and integrates the visual system, how the head is moving, that's the vestibular system, and all the information that we talked about coming from the muscles and the joints and the tendons, which is the proprioceptive system. So it has all this luxury information on top of the motor information coming down from the brain. So the plan, what is the brain trying to do in the next second, to really modify that motor plan and make it precise, okay? So if I have damage here, I can engage the cerebellum to do a lot of connection to the spinal cord, to control muscle tone, to control that myotic reflex, not without the boss, but now using the intermediate station, the cerebellum, by just giving a lot of variation to the body position, to the movement, to acceleration, to the head position. And we use this in rehab. I'm gonna mention that there is something which is the tree house, the basal ganglia, that is on charge of all the no connections to the outside, but the planning of that motor plan is important, because some kids have injury to the basal ganglia and they will have dystonic CP. So when they wanna move, the tone goes into a very wrong place when you're trying to move. You go to sleep, that muscle tone disappears. And I'm gonna pass it now back to Mara. And between the two of us, we wanted to walk you through incorporating these concepts we were discussing into the experience and how you can observe these things. And in a way, start instructing and using them to produce that learning experience. Remember, the kids are most of the time spending a quality interaction that it cannot be replaced with the parents. So here I'm gonna let Mara drive from now on. Mara, I'm gonna stop sharing and you will share.
No, I actually want you to keep sharing.
Okay.
So just before we start showing these video clips, this is the third time that Patty and I are presenting like this. And every time I learn a ton. And I actually even feel that way. I've spent multiple hours with Patty this week preparing to present this time. And the pace and volume of what she just shared is too much. I need to go watch the video on slow motion to capture it. So, and each of us has things to say about every video. So what I want you to do is pretend you're in the room with us as we were preparing and choosing which videos to share with you. And they're videos that I somehow knew to capture because of my education with Feldenkrais and this applied neuroplasticity. I was watching as a trained observer my own child's development, and I was interfering in gentle ways to promote learning and development along the lines of what you've been hearing about. But both Patty and I have different things that we see in these videos. And so we'll try to bring that out and invite you to also take on this role as an observer. So in this first one, I've just put little cues at the top. Mia's right hand is affected by the stroke, potentially. And I'm in this like wait and see mode. Mia's not even 2 months old at this point. But the car seat right here is actually holding that right elbow such that Mia's making connections with the right hand and the right mouth and the mouth. And again, you remember from that picture of the homunculus, the hand and the face and the mouth are all very close in the brain. So this is even like saying, I have a hand to that part of the brain that exists. And Mia's half asleep here. So it's really remarkable how much development is going on just to know which parts of the body are in the self-image of the infant.
And Mara, she's gonna show us something that is called tonic neck reflex. And it's in this picture that you see in the frozen frame of the video. And that's why the car seat was helping, because when the head goes to one side, we go into this fencing kind of position. That's what we call the tonic neck reflex. So in the floor, it's not so easy to get your hand to the mouth. So I'm gonna play this one. Mara, you can take it from there.
So in this one, I've put Mia on a play mat, and I'm actually trying to promote that Mia can swat at that toy that's a little bit above and to the right. And there's cause and effect. Like I hit the toy, I have agency. And I knew Mia was doing that consistently by 3 months with the left hand, but I was trying to have Mia have an experience of doing it with the right hand. And I had to, bias the environment a little bit, but you see that it captures all of Mia's attention with vision and sound. And then that reaching, again, even though the reaching is not so skillful because of the asymmetrical tonic neck reflex. This one, again, is bringing this theme of hand to mouth. And you'll see that Mia actually in this whole clip spends much more time mouthing the right hand, which is partially fisted, than the left. It's almost like I've already mapped the left hand. I know where those fingers are. I'm leaving that alone. It's maybe not so interesting, but there's some novelty in mouthing that right hand.
And I wanted to remind you of the first video that you saw when Mia was in the office, where that hand was fisted. And when she was trying to do something else and it wasn't a sensory, and you can see right here, it goes much more stiff. No, that myotonic reflex takes on again. If there is no something telling that motor neuron that we can do something else. And that's how when she's with the mouth in her hand, the fingers are opening more. And you can see the repertoire of movement changes dramatically. So again, how she's using different modalities to kind of provide that lower level of execution of the muscle with the information that is needed to provide more experience. It's like a retro feedback all the time. Sorry, every time I click, it comes to the same video.
So you'll see there's several of Mia in the same outfit with these orange pants, but in different relationships to gravity. So again, this is a favorable position where Mia's lying on the left side and gravity is sort of supporting that right hand and arm in hanging downward, and the toy is not heavy. So Mia can hold and manipulate it with the more skillful left hand and still interact with it with the right hand. And you'll see this bias of handedness was very strong. So I'm handing Mia the toy straight on, and Mia grabs for it purposefully with the left hand, and Mia's right hand is really quiet. So one of the things that I wanted to point out with this video is with the left side, Mia's introducing just tons of variability and variation. And with the affected right side, that's muted. There's just not as much variability. So it's almost like we as the parents have the job of tweaking the environment to introduce more variability for the affected side.
And if you guys were watching throughout, I don't know if you've been paying attention to the feet. The feet are not steady or completely not in movement. They're constantly also providing another experience that is helping and informing the brain and whatever is happening with the hands.
Next one.
Mhm.
So we're shifting, Patty helped sequence these video clips in our prep earlier this week. So if you turn your volume up a little bit, you'll hear Mia's vocalizing here. And so remember that vocalizing takes movement too. It's just tiny, refined movements of the mouth and tongue. And the rest of Mia's body gets much quieter while Mia's making sound and making sense of that sound and the possibility of making sound. And this is a couple months later, and you'll see that the capability of making noise has increased to these blowing raspberries with the tongue and the lips.
And you can see how the cooing is also evolving. She's using the tongue in different parts of the mouth. And you guys can see when she stops talking, the repertoire of the hands increases again. Okay, every time that she's working on this, she's quiet a little bit. And then when she makes a pass, she gets with the hands going. And then at some point, everything goes.
So yeah, so Mia's clapping the floor. You'll also notice that that's the kitchen floor. And at 6 months, Mia was pretty happy to be on a hard kitchen floor. Whereas when Mia was younger, mostly I had a mat or a blanket on the carpet with a carpet pad. So it was a firm but padded environment. And now there's some advantages to being on the slippery floor. You'll see there's even more vocalization and social interaction with smiling and interacting with me and the camera. And in this clip at the end, Mia actually rolls all the way over.
Looking at you. And I don't know if you guys noticed that Mara is not chatting alone. There is not editorializing of the experience or distracting. It's a little bit of a stepping back and observing and just watching, contemplating. And that also informs you. There is going to be a lot of information you get from that and a lot of emotional connection if you allow that slowing down in yourself too to happen. It's very easy to start saying, oh, what are you doing? And da, 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 da. And that brings another sensory experience for the kid that may be a little bit too much sometimes when they're working hard on something difficult.
And you saw Mia got stuck at the end there, as most kids who are learning to roll, they get stuck on that bottom arm and they have to figure out how to shift their weight so that they can pull, in this case, so that Mia can pull that right arm out and complete the transition. So this is another couple weeks later, again on the kitchen floor. And the environment, I'm not a perfect housekeeper by any means, but the environment's relatively simple. There's not a ton of clutter. There's sort of one or two things to interact with. In that case, I think I kicked or pushed the baby doll. So Mia would reach for it with the right arm And you see really using both hands together to play with something that's a little bit bigger.
And in contrast to, again, the first sequence that we show, now she has a lot of control of her trunk and is able to support her head and her chest up without the stress and the difficulties that happen in the 3-month-old. And one of the most common things we hear all the parents are experiencing is belly time, belly time, belly time, belly time. Belly time is not the way you're gonna get to learn to use your body when you are yet not ready to